This lecture is for 598C, Aging and Mental Health. This is for week 7 of our class. And in this week, we're going to talk a lot about death and death and denial, death and aging, as it is a profound and regular experience. The older one gets, the more and more of one's friends, family, significant others die. And then, of course, facing one's own mortality as one nears the end of one's life. So we can think about our society as a death-denying society. We tend to be uncomfortable with death. We tend to use euphemisms for death. Some of them are more gentle in nature, passing away. Others are much more maybe negative. Kicking the bucket, for example, is something that comes to mind. Additionally, we are fascinated by unrealistic, violent deaths, as shown on TV or in movies, true crime kinds of experiences as well. Technology has replaced religion as a way of understanding death. Medicalization has also impacted our views of death. The end of biological life, the idea that there's nothing transcendent upon the end of one's physical existence. 85% of American deaths occur in hospitals or nursing homes, speaking to the idea of the medicalization of this. And of course, healthcare professionals aren't trained necessarily to deal with death. They are trained to deal and extend life at whatever cost, it would seem, as well. So trying to think about balancing one's quality of life as compared with just having life itself. And of course, as America ages, this topic in death, the death topic has increased dramatically, as well as the ethics related to it, which we will delve into a little bit later in the presentation. So, of course, Kubler-Ross has had a profound impact on death studies. Her famous model of the stages of death and grief, as we are going to go through them. Now, remember, these are about the individual experiencing or receiving a terminal diagnosis, and so it's how that person adjusts to the idea of their impending death. Now, impending or imminent, that could extend, months or years. A cancer diagnosis, a terminal cancer diagnosis, might not have like a couple of days or a couple hours down the road. The person could be experiencing a longer term dealing with their death, and so remember. There's high variation in this idea, or in these stages of death, dying and grief. So the individual might be at any stage or several stages simultaneously. And further, you don't have to deal with them sequentially. You don't have to move through them one after the other. So a really good heuristic is DABDA, D-A-B-D-A, D-A-B-D-A. And so, right, denial and shock, there's just an unbelief that I've received this diagnosis or my death is imminent. Anger is the next stage, being angry at God, angry at the doctors, angry at everybody, having received this diagnosis. Bargaining, if I'll do this if this can happen or that can happen. Usually making these bargaining arrangements with one's transcendent beliefs or God. I'll live a better life. I'll give all my money to the poor if you'll take this from me. That kind of a thing. Then going through a serious depression, not necessarily a DSM level depression or conceptualization of depression, but extreme sadness and darkness and emptiness and meaninglessness, and then finally one accepts the diagnosis. Now, many therapists and psychologists, family therapists, counselors apply these stages to everyone in receiving or in dealing with the grieving process. And so many therapists would talk about how individuals that aren't imminently dying go through this process when a loved one passes away. Denial and shock. I can't believe, Joe's not here anymore. Anger at the person or the causes or at God over the loss of a loved one. Bargaining. Oh, if you could only bring him back or her back, I would do this, that, or the other thing. Take these experiences from me. Of course, grief, which is part and parcel of bereavement, is dealing with sadness. Death is a qualitative shift in one's relationships, right? It's not a quantitative shift, adding more happiness, adding more joy, whatever that is. It is a fundamental change in the way that the relationship works. That person is no longer there. And so it's a qualitative shift, which necessarily means sadness occurs, meaninglessness, depression, all of those things. Acceptance, accepting these new changes, coming to terms with them, with the new normal, quote-unquote new normal kind of an experience as well. So all of these things are part and parcel with how therapists would work with those that are still alive in coping with the dying process. So I want to emphasize here a couple things. One is depression, not clinical, right? Not a DSM idea, but that's a normal response. And so as you should recall from your psychopathology class, your DSM class, in the previous iterations of the DSM, grief and grieving and bereavement was an automatic rule out for depression or a diagnosis of major depression disorder, indicating that most people believe that it's normal to be sad, depressed when someone you love dies. That is no longer the case in the DSM-5. So technically speaking, someone that's grieving could be diagnosed currently with a major depressive disorder. So that's something to think about as you are dealing with these issues in your own practice. Another important thing to think about, especially for older people and dealing and doing therapy with older people, is what are the components that affect the life cycle of older people? Reminiscence is this process of recollecting memories and integrating past experiences into the present moment for the elder and make projections for the future. This is very connected with the final stage in Erik Erikson's model, where the older adult is engaged in this process of reflection and thinking about, boy, I did a really good job, right? I've invested in my offspring. I have invested in humanity through my work, through my family, through my life, through my community, and so I have this sense of integrity that I've done well. And I can pass these things on. I have a legacy, and I can reminisce about those things. On the other side, there's the idea of despair. What if the older adult has not been a successful person, has damaged their children, has not really contributed to humanity? And so this life review is a good way for us as therapists to go through the process and help older adults to engage and to reflect on their contributions. So specifically, this life review is a form of reminiscence. The reviewer actually evaluates the past and attempts to resolve conflicts, and so the therapist can begin to ask questions of the older adult to engage in the process, to listen to the life story therein. And so Bernice Neugarten talks about this idea of interiority, referring to a process common in mid and later life where one becomes more focused on internal experiences, one's own contributions, one's own meaning, one's own expressions, and not so much in terms of their social focus. And then, of course, as death becomes more and more imminent, there's more and more focus on the inside, in the interior, the specific meaning making that way. And so this life review helps us to cast that, move toward more of an interiority in terms of looking at an integrity and an integral perspective. Yes, I've made great contributions. I've made significant investments in my family, in my grandchildren, in my job, in my profession, in my community, in my church, my synagogue, my society. And so that really impacts this idea of one's interiority. It's a more pleasant integrity experience as opposed to this idea of despair, having lots of regrets in one's life that way. So when people are dying themselves, of course, because of the medicalization of it, it leads to this idea of conflict. Suffering is medicalized in our culture in the United States. If you're in pain, we need to find ways to stop the pain. It's a medical approach. So we give people Vicodin. We try to ease their pain through other means, and not really understand that oftentimes psychological pain is very appropriate, and we need to embrace that experience and move forward in it to cope with it. And so this leads to also a conflict between individualism and autonomy, my choice in doing certain things to make rational, reasonable, to exercise my own autonomy. And so then how, the doctor knowing best, the medical profession knowing best for my care versus what I know. And we engage in this, and we think we are part of this as well. As therapists, we obtain informed consent when we interact with our clients in the beginning of therapy and throughout therapy, and trying to identify the best treatment plan for them, but also enlisting their cooperation. Will this work for you? Do you think this is a good idea? And having their consent in that process. And so those processes impact how we understand death and dying. The level of treatment at the end of one's life is an important component to this. So we can think about how, especially on medical wards, how this idea of does the patient know about their impending death? And so a closed awareness perspective means that the information about the impending death is kept from the patient, from the medical team. And so the patient's not necessarily aware that they have a terminal diagnosis, but the medical staff do, and that can very significantly impact the level and quality of care that the individual receives from the staff. Suspicion awareness: the patient suspects the truth, but no one will confirm it. So the patient begins to have the idea or the sense, maybe based on how he or she being treated, or maybe the family being treated, that they do have a terminal diagnosis, death is impending, but they haven't been told about it. There's this idea of ritual drama, of mutual pretense. Both patient and staff know that death is impending, but both choose to act as if it is not. So people pretend as if, and then carry on in the hospital during their care. If the family chooses not to engage in the process as well, so they act like the person is going to get better. The staff act as if the patient is going to get better. Those kinds of things. And then finally, we can think about another way of awareness is this open awareness, where patient and staff openly acknowledge that the patient is dying, and then they work to make that person's death as dignified as possible. The challenge is, of course, the medical profession would view death as a negative outcome, right? That would be the worst medical outcome, because medicine is supposed to keep you alive. And of course, the individual ideally doesn't want to die, and the family, of course, doesn't want their loved one to die. And so there's a lot of investment motivation, that is, to keep death at bay for as long as possible, which impacts closed awareness, suspicion awareness, ritual drama, and also open awareness. And so some questions to ask: that should a medical professional tell the patient he or she is dying? Does the patient have a right to know? Connected with this is also the idea of mental health diagnoses. Should you tell your patient or your client how you've diagnosed them? What role does that play in the treatment process? What information, is knowledge power, so to speak, and is it empowering to the patient? Stereotyping the term terminal patient is dying and forgetting other aspects of the person. What's the impact, of the death, this terminal diagnosis on the person? How does that impact their treatment? How do we offer hope? How much hope to offer? And the dying can represent failure and hopelessness to the doctors, which means that it can also impact their willingness to treat them, their willingness to treat them as people. It can impact their bedside manner, their engagement with the person as well. The hospice model is a powerful experience, and some of you may actually choose to get hospice training. I have not done it, but I know several people that have, and it's a beautiful, supportive, humane way to be along with the client and the family and the individual as death is coming closer and closer, to make the person comfortable, effective pain relief. It helps the person become comfortable and dependent as long as possible. There's lots of psychological support through the stages of dying. There's also support for the family and dying with dignity, and this whole idea of facing one's imminent death and supporting the family and the individual coping with the stages of grief and dying and moving into saying goodbye. And it's very dignified approach. Dying in a familiar surrounding, like one's home, one's family, that experience is powerful and healing for both the person and the family in that moment. Palliative care is the medical specialty focused on relief of pain, stress, and other debilitating symptoms of illnesses. There have been huge advances in pain care. However, the problem is that they're mainly psychopharmacological in orientation. Pills, which can be problematic as dealing with a whole bunch of other factors. Other psychological approaches to pain management are less and less used in this medical specialty. And so as we were thinking about this, one of the roles that we could play is to engage the medical professionals. One of our jobs as therapists sometimes is to advocate on behalf of our clients with their permission in dealing with the medical professionals that they are interacting with. And so we can begin a psychological approach with the pain management and other kinds of things like that. So just think about that as well, as we are going to be treating more and more older adults in our experience. So this brings us to this idea of the right to die. Do individuals have the right to commit suicide? If I have received a medical diagnosis, a terminal illness, do I have the right to go out on my own terms? So the first bill to legalize doctor-assisted suicide was introduced in 1906. This movement grew until the end of WW2, mainly because of the Nazi death camps. The systematic termination of life became abhorrent. Actually, there are some eugenics components to this right to die, understanding that way. And so, at any rate, this right to die, do we have the right to die? I've received medical illness, and I don't want to die, a horrible, painful, suffering death. So I want to maybe die 6 months earlier than that. Those kinds of things. And what role does medicine have in this? And so these are hugely important ethical components. So from a Christian perspective, is it okay? Does God allow death in this moment? And then what do we do with depressed people? Do they have a right to die? Because now remember, we are obligated to take certain steps to prevent suicide as a mental health professional. So there's a lot of challenges in this idea of the right to die. Some important cases: Karen Quinlan lived in a comatose state for 9 years after life support machines were removed. Cruzan versus Missouri Department of Health, long series of decisions finally resulted in her feeding tube being removed just months before passage of a law requiring healthcare facilities to inform patients of the right to have a living will. Terry Schiavo's husband was granted the right to have her feeding tube removed after 15 years in a vegetative state. So there are lots of individuals that have dealt with this, where where the body, the shell has been maintained. However, the person is brain dead, or right, their brains aren't working, or they're comatose, unable to interact with their environments. And so some issues here. What's the difference between killing and allowing a person to die? Right. So the medical intervention, maybe providing some kind of deadly substance, or allowing the person to die, that is removing the feeding tube, removing the respirator information, machines that way, those kinds of things. And how does that impact the person? What's the difference between stopping treatment and not beginning it? That was a core issue. So if the person refuses treatment from the beginning, is that different than having a medical professional stop treatment at some point in the process? Are there reasonable and unreasonable treatments to prolong life? So as a result, there's been this push to have an advanced directive, which gives specific instructions to doctors regarding what kind of care a person wants to have. If he or she becomes unable, unconscious, demented, some kind of cognitive impairment, preventing medical decisions to be made. Nearly 90% of Americans will have a managed death in a healthcare facility, so these are really hugely important. Even accidentally, like if you're driving down on the freeway and you're in a car wreck and then you're comatose, what will happen to you after that? You can't you can't interact and tell doctors what you want to do. Does your family have the power to talk for you in that moment? And how that process works out. Only about 30% of Americans have an advanced directive. So one of the important things to do with many clients, especially the older adults, but even the middle-aged folk, is to talk with them and have them think about advanced directives. Have you thought about medical treatment? Signed any do not resuscitate papers? Who has the durable power of attorney? That kind of a thing. So it's some important information to think about. Your living will is a written document describing the kind of life-sustaining treatments you want. If you become terminally ill, it does not allow you to select someone to make the decisions for you. So that doesn't give you a durable power of attorney. The durable power of attorney states whom you want to make decisions for you. And this only becomes active when you become unconscious or unable to make medical decisions, which includes dementia. And then a final component of this is do not resuscitate, requesting that in the case your heart stops or you're not breathing, that you don't want CPR, you don't want to be resuscitated. Because the results can be, you could be resuscitated but then put on life support machine. However, you're not able to interact. You might be in a comatose state at that point. Some more terms. Passive euthanasia is a process of allowing people to die without using extraordinary means to save their lives. So not giving antibiotics, for example. Assisted suicide is performing a deliberate act to end a person's life, administering a fatal injection or allowing them to administer the fatal injection via intravenous transmission process. And of course the line between these two is not always clear. So the Patient Self-Determination Act was passed in 1991, and it requires all healthcare facilities receiving Medicare and Medicaid to recognize the living will and the durable power of attorney for healthcare. Patients must receive written information on their rights about these things. Between 40 and 50% of physicians currently believe that physician-assisted suicide may be ethically permissible, and around 60% favor its legislation. 2006, via Supreme Court ruled that it was up to the states to regulate this medical practice, and older persons are less likely to believe it is appropriate. And of course, Dr. Kevorkian has been the most visible advocate, and also he's been in legal trouble, if my memory serves, related to assisted suicide. In 1997, Oregon became the first state, passing a law to allow doctors to hasten the death for the terminally ill. 2008, 60% of voters in Washington state passed legislation, and the issue remains controversial. It hasn't been passed yet, but there have been some political maneuverings and legislation that hasn't made it all the way through here in California. But anyway, it's important for us to keep abreast of these kinds of situations and what they mean for our practice. Not that we would be involved in the assisted suicide per se. However, what's our role in helping our clients make the informed decisions they need to make for durable power of attorney, living will, and the DNR orders. And also it gets into depression. If I have an older adult that's depressed and they want to commit suicide, do these kinds of situations apply? Especially when depression is so prevalent among older adults, number one, and number two, it's also co-occurring with many physical ailments like heart related diagnoses as well. So informed consent, it's important to think through how do we obtain informed consent, especially for the older adult. Is a person competent to give general consent? Is it freely given? And does the older adult fully understand the meaning of the options? This is crucial when you're seeing an older adult in your private practice, or in any agency for that matter, to identify who has the right to consent, and is this older adult competent? And so if the family tells you that they're incompetent, or if you get the sense, it would be very important to get the paperwork. Does the person have a guardian, a caretaker, a durable power of attorney, that kind of a thing, as you were trying to be ethical in your practice. So some other thoughts about some more ethical questions. What's the appropriate level of direction family members in the healthcare system should provide when dealing with a person who's losing competency? With regard to the ethics of nursing homes, how much self-determination autonomy is allowed for the older person to make decisions and act for him or herself? And what obligations do adult children have for the financial, physical, and emotional support of their elderly parents? So very important questions. Further, in terms of facing and preparing for death, and these are very helpful questions to think about with your clients, especially your middle adults and older. Do you have a will? Do you have life insurance? What about advance directives? How about autopsies done on your body? Chosen organ donation? Do you know how funeral arrangements have they, been made? How does that work? What kind of last rites do you want? Bereavement is the process of experiencing loss that is of someone that's very important in our lives, and then how we adjust to that loss. Grief is the emotional response experienced throughout bereavement. Mourning is our behavioral response. Complicated mourning is a cognitive disorganization and emotional chaos that can lead some people into profound depression. Now remember, as we talked about earlier, depression is one of the stages of grief and loss. And so it's very normal to feel grief and an immense and immediate and long-term depression, sadness over that. And then going through this mourning process is our behavioral reactions to that. And now sometimes these can be complicated and lead have a longer time and a more profound disorganization and emotional impact on people. So the DSM-5 would suggest if that's the case, then this person could or should be diagnosed with a major depressive disorder. Bereavement is more on bereavement. Chronic grief reactions involve reactions to death that are of long duration and do not lead to resolution. Masked grief reactions are the complete absence of grief reactions accompanied with substantive psychosomatic complaints. And finally, exaggerated grief reactions are repressed to formal grief-causing situations, and then clinical depression is similar to profound sadness. So it takes discernment as we're helping older adults, or anyone for that matter, go through grief and loss, to kind of discern what kinds of grief is it. Is this normal? Is it masked, chronic, exaggerated, or is it actual clinical depression? And then what are the concomitant steps that we need to take? This concludes week 7's lecture on death and aging for PSY 598C, Aging and Mental Health.